couple of decades ago, most people were treated with a total thyroidectomy. You require lifetime thyroid hormone replacement. Sometimes you're at risk for other problems, chronically low calcium levels, injury to the nerves that are going to the vocal cords. It's really quite an potentially impactful surgery. If we can find ways to de-escalate the treatment, removing, as you say, part of the thyroid, perhaps observing in some people, and now thermal ablation, it would be beneficial because we can avoid those complications that I just talked about. Having a tool that more exactly tells you the likelihood of a structural recurrence is going to be integral to that decision making. And Thyroid Guide PX has the capability of identifying a group of patients who have a less than 4% recurrence rate. So those would be the perfect patients, could be considered for these more conservative treatment approaches.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Oliver Bathe, the CEO and founder of Qualisure Diagnostics. Dr. Bathe is a surgical oncologist with over 25 years of clinical experience. As a result, he has an excellent understanding of the challenges that patients and clinicians face during their cancer journey. He has been involved in research that applies cutting-edge technological solutions to real clinical problems. In recent years, Dr. Bathe founded Qualisure Diagnostics, a company that develops molecular tests that enhance cancer care by identifying features that help oncologists personalize treatment. Through innovation and collaboration, Qualisure helps clinicians decide on the right treatment to provide personalized cancer care to every patient. Dr. Bathe, welcome to the podcast.
Thanks very much for having me, Jen.
I am very excited to have you here with me today, Dr. Bathe. I would love to tell a little bit of the story of how we met at the ATA meeting, if you don't mind. So just to give the viewers some context, I was able to attend this year's ATA, American Thyroid Association meeting in Washington, D.C., and that was actually the first time I was ever able to do that. So it was very exciting to go to that meeting. I was also very excited because at this year's meeting, ATA did their first ever thyroid thermal ablation workshop. I was able to attend that as well. And just as a side note, the ATA just released their guidelines, their first ever guidelines for thyroid ablation techniques for benign thyroid nodules. So this was a big deal. And I was really excited to be at this meeting because now the ATA is effectively endorsing thyroid thermal ablation techniques. Just for anyone who's watching this podcast and doesn't know what thermal ablation is, that's just an umbrella term for ablation technique that uses heat to destroy thyroid nodules. I was at the ATA meeting, and the second day I was there, I was sitting at the exhibit hall with my good friend and mentor, Gary Bloom, who's the executive director of THICA, Thyroid Cancer Survivors Association. I excused myself to go to the ladies' room, washing my hands. I happened to be a few sinks down from Alicia, who works with you. We struck up a casual conversation. That's what ladies do, right? It didn't take long. We realized that this conversation was not just a coincidental encounter, but actually it was quite providential. We went back to the exhibit hall, and she shared with me all about Qualissure's testing, then later introduced me to you. And then I brought Gary over to the booth to meet you and to learn about the testing. It was just an amazing encounter. And I'm so grateful that we connected there because there's so many implications for the testing that Qualisure makes for the patients that Save Your Thyroid helps. And so I'm very excited to talk more about this today. Also for patients and doctors to learn more about this because this is fairly new. First, tell us a little bit more about yourself.
So I'm a surgical oncologist. I've been practicing for over 25 years, and in parallel to my clinical practice, I've had a research lab. So actually, my practice is not in the treatment of thyroid cancer, but it was in the treatment of liver cancers and pancreas cancers. And as you can imagine, those are very aggressive tumors. And so, my whole focus on my research was to develop tools to help to refine the clinical decision making for those cancers. 7 years ago, as part of a project for a postdoctoral fellow that was working in my lab, what we did is we created a machine learning algorithm. And what it does is it scours really large genomic databases to identify the molecular features of cancer that are most closely related to survival outcomes. So we use this algorithm in about 11 different cancer types and put it on a supercomputer, a national supercomputer. And within a couple of weeks, we got some really interesting data and molecular signatures that helped us to distinguish whether a cancer is aggressive or not. So I showed this to some of my colleagues, and the ones that were most excited about it were the thyroid surgeons. The reason that they were so excited about it is that because they really were in need of a tool to help to select the best treatments for those patients with thyroid cancer. And as you know, thyroid cancer isn't often a life-threatening cancer, but it's a serious cancer.
Definitely.
And what we want to do is avoid overtreatment. And so we established a collaboration based on that.
So you've got this extensive background, both as a clinician and as a researcher. So tell us about your experience in biomarker research and how this somewhat accidentally led to you becoming the CEO and founder of your company, Qualisure.
My intention was never to be a business person, as you can imagine. My intention was really to develop tools to help clinicians to make better treatment choices and also to help patients to avoid excessive and unbeneficial treatments. But what I've come to realize is if you really want true adoption, then unfortunately, commercialization is really essential to that whole process. Mm-hmm. Really, the research team that helped to develop this has been integral to developing that company, Qualisure Diagnostics. We continue to do important research to enhance the evidence that our test, which is called Thyroid Guide PX, does what it's supposed to do. And it's a very unique test because, so far as I'm aware, there aren't any other tests that are built specifically for papillary thyroid cancer to help make these treatment decisions that you're talking about.
Yeah, and I want to talk more in just a moment about the specificity of this test being for papillary thyroid cancer, because we did have some questions from the SYT community about that. I want to take a moment to kind of give our viewers just a little bit more context about papillary thyroid cancer, PTC, as some people like to refer to it. Thyroid cancer is actually considered a rare disease, but the incidence of thyroid cancer is increasing about 6% per year. Papillary thyroid cancer is the most common type of thyroid cancer, about 80% of all thyroid cancers, and is not usually life-threatening, which is why it's so important to figure out these treatment options, right? Because you don't want to compromise a patient's quality of life if they're going to be very likely to survive. Papillary thyroid cancer does not usually spread outside of the neck to distant parts of the body, but it can metastasize to local lymph nodes in the neck. In the past, this cancer diagnosis always meant that a patient would need to undergo surgery, whether it be a total thyroidectomy where they remove the entire thyroid, or just a hemithyroidectomy where they remove just one side of the thyroid. As many people know, the thyroid is shaped sort of like a butterfly. In some cases, the thyroid can be only half of it removed. And then in more recent years, we have added the concept of active surveillance, which I think is going to be really important with this test in determining which patients are good candidates for that. In appropriate patients, we can actually not treat and just watch the cancer. But today, some papillary thyroid cancer patients may be candidates for also non-surgical treatment options. And we've talked about that topic at length on this channel. So if anyone would like to watch videos about that, if you're unfamiliar, please see my thyroid cancer playlist, which will be linked in the description of this video. You already mentioned that the reason you kind of started with this was because the thyroid cancer surgeons were so excited. Let's discuss the risk recurrence of papillary thyroid cancer and how that maybe plays into that.
As you mentioned, Papillary thyroid cancer doesn't tend to be life-threatening, although it can be in some individuals. What's really more impactful is the risk of a structural recurrence. In other words, the cancer coming back and requiring a second surgery. For years, thyroid surgeons and endocrinologists have tried to develop tools to determine the risk of that structural recurrence, and that helps them to determine the best treatment pathway for individuals. A couple of decades ago, most people were treated with a total thyroidectomy, which means that you require lifetime thyroid hormone replacement.
Right.
Sometimes you're at risk for other problems such as hypoparathyroidism or chronically low calcium levels. You can get injury to the nerves that are going to the vocal cords. So it's really quite an potentially impactful surgery. So if we can find ways to de-escalate the treatment, removing, as you say, part of the thyroid, perhaps observing in some people, and now thermal ablation, it would be beneficial because we can avoid those kind of complications that I just talked about. Having a tool that more exactly tells you the likelihood of a structural recurrence is going to be integral to that decision making. And Thyroid Guide PX has the capability of identifying a group of patients who have a less than 4% recurrence rate. So those would be the perfect patients could be considered for these more conservative treatment approaches.
What if I'm a patient who has had surgical complications in the past and I don't want to have any more surgeries, and I take this test and I find out I'm one of those less than 4% recurrence? So that would mean if I'm that patient, it's pretty unlikely I would even need to have surgery. Perhaps do active surveillance?
Yeah, possibly. I think that takes a special kind of patient as well, of course, someone who would be able to tolerate the need for frequent follow-ups.
Right.
Not everybody has that capability. Some people are too anxious to do active surveillance. I would certainly be comfortable with that, but other people want a particular treatment. So, when it comes to the treatment, you can also find more conservative management approaches that would hopefully avoid those side effects related to a total thyroidectomy.
You talked briefly about the machine learning that was used in the development of Thyroid Guide PX and the 3 biologically distinct subtypes of papillary thyroid cancer that were discovered. Can you tell us more about that and how it differs from the ATA, American Thyroid Association, risk stratification system?
The machine learning helped us to identify 82 genes that are really closely related to structural recurrence. And then what we did is we looked for patterns of expressions of those genes, kind of like fingerprints. And we identified 3 patterns that were really, really interesting. The first one, which we call type 1, has a lot of papillary thyroid cancers that are called follicular variants. And they had a certain pattern of mutations, what we call RAS-like tumors, had a low incidence of metastasis to the lymph nodes. And so they were really interesting from that perspective. And then on the other extreme, we had a type 3 tumor, which had a very high incidence of recurrence, had a lot of what we call TERT mutations, which tend to be related to recurrence rate, and also had some other bad features. What was also really interesting about that is that there were some similarities in the pattern that you would see in what's called anaplastic thyroid cancer, which is a very aggressive thyroid cancer. And then there's this type 2, which if you looked at it under the microscope, it would be clinically indistinguishable from the type 3, but it has a very different pattern of these 82 genes and has a very, very low recurrence rate, even the ones that have TERT mutations. So there was some really interesting biology that I think that will merit some further research.
So it sounds like there are things being discovered here through this machine learning that when a pathologist is examining this under a microscope would not be able to determine.
Absolutely.
Wow.
I think that we've been very reliant on looking at the size of a tumor and looking at the microscopic features of a tumor. There are some features that we know are higher risk, but they don't always mean that for sure you'll have a structural recurrence. So what this approach, looking at the molecular features of a cancer, the advantages of that approach is that it really informs us on the underlying biology of a cancer. So you can have a very small tumor that you would think because of its size has a low risk of recurrence, but if it has really aggressive biology, then it actually confers a much higher risk of recurrence. There are some other really big differences from the American Thyroid Association clinical risk score. And probably the most important thing is that you can actually do this testing prior to the surgery. Whereas with the American Thyroid Association clinical risk stratification system, you need all the pathology information, you need all of the microscopic details to help to inform the risk estimation. So doing this all up front informs the entire treatment pathway as opposed to using the ATA system where you look at it after surgery. And sometimes based on those findings, you even need a second surgery. So we think that it'll avoid that necessity to do a completion thyroidectomy.
That's something we just had a patient ask about this just the other day about why is it that in some cases you'll hear a patient talk about during their thyroid surgery pathology run on say they have half of the thyroid removed. They run pathology on that while the patient is under anesthesia. If they find cancer, then they go ahead and remove the other half versus you go in and have a surgery. They run the pathology and then, oh, sorry, it's cancer. You need a second surgery. And unfortunately, it is not like that everywhere in the US. But in my particular experience here locally where I live, that was actually what was offered to me when I was considering having thyroid surgery for my benign mass. I was grateful for that on the one hand to have the potential of only having to lose half of my thyroid. But I was also kind of scared by the fact that I could wake up from surgery and not know what the expected outcome was. I kind of digressed there a little bit, but having this knowledge before going into a surgery and having the ability to make your treatment decisions rather than, what we hear a lot is patient had surgery and they have their pathology come back and it's benign and they're so relieved and they're so excited. And I'm like, but you had surgery and you maybe didn't need to. I wouldn't be relieved. I would be more, upset. But at the same time, oh, well, at least I didn't have cancer in there, So again, I've digressed, but
Well, I think related to that is another problem. So say you knew that it was cancer ahead of time
yeah.
and it was a really small tumor and your surgeon suggested doing a hemithyroidectomy. Then they look at it under the microscope. They find these features in there like vascular invasion or what's called tall cell variant, which usually suggests a worse prognosis. Then they might actually suggest removing the remainder of the thyroid in a second operation. And that's really stressful on patients, stressful on the doctors as well. It's a much more difficult surgery. So if you can avoid that eventuality, that would be great. And having all the molecular information up front would, I think, avoid that scenario.
One of the common issues we see with a lot of surgeons who are not informed on how thermal ablation works and doesn't typically cause a lot of scar tissue in the neck is their concern for going into the neck afterwards. And is there going to be scar tissue caused by that, say, RFA procedure? Well, I'm assuming in this case where you're talking about a patient who's undergone a hemithyroidectomy and then they need to go back in, that's an issue. And then especially if say they come back and say, oh, well, now you actually need a radical neck dissection. So there's going to be even more tissue that's removed during that second surgery. This kind of makes that a non-issue.
Yeah, I believe so too. If you know exactly what your treatment is up front, you can avoid that scar tissue issue. You can avoid having to go through several operations and changes in your operative plan. That is stressful on everybody. So just having that information up front is really beneficial.
So did Qualisure actually coin the term subtype 1, 2, and 3?
Yeah, we just didn't have any better words for them. I mean, to be honest, there are some really distinct features of these cancers from a biological standpoint, but then you would end up with these great big long names that wouldn't be very useful. So type 1, type 2, and type 3 is where we landed at.
And the reason I ask is because I've never heard those terms before. So I thought maybe that was unique to your testing. So with the type 1 and the type 2, we've got a less aggressive profile and less likely to metastasize in the neck. And then with the type 3, we do have a more higher risk of that happening. And so with the patients who are a type 1 or a type 2, would they be candidates potentially for active surveillance or for radiofrequency ablation?
Yeah, we haven't actually done big studies on people who are undergoing active surveillance. So I think that's some research that is required. But
Okay.
looking at it intuitively, those would be the ones that have the slower growing tumors. So those might be good candidates and
Hmm.
would, if there's any degree of anxiety in patients, then the results of the test might help them to feel more comfortable with that approach.
Hmm.
On the other hand, if you knew that you had an aggressive cancer, then that might sway you away from active surveillance.
Sure.
Again, we don't have any large studies based on that. That's just based on, intuition. Similarly, if you have an aggressive cancer and you know it up front, then you're going to want full treatment. There's still a lot of room for clinical judgment here because if you happen to have a very large tumor and you have lymph nodes that are, your surgeon can feel them, then that is obviously not a situation either, which would be
Right.
good for conservative management and should
Hmm.
be treated more aggressively. So really the molecular testing is probably most helpful with the smaller, earlier tumors.
Right. Because today's landscape of treatment with thermal ablation, what we're seeing is that patients with sub-centimeter tumors aren't being treated. Patients with a 1 centimeter up to as large as two, sometimes even 2.2, 2.3 centimeter papillary thyroid cancers without any lymph node involvement are sometimes candidates. I say sometimes because it does matter where the tumor is located. The tumor does need to be well within the inside of the lobe of the thyroid gland and not near any of the critical structures in the neck. And so a patient who has a diagnosis of papillary thyroid cancer, who has a tumor that is between 1 centimeter and 2 centimeters, well within the thyroid lobe, and then takes this test and finds out I have a type 3 papillary thyroid cancer, would not be a good candidate is what I'm understanding from what you're telling me, Dr. Bathe, because they would have that more aggressive profile. Even though all of the features of the tumor itself are ideal for treatment, they're going to be way more likely to have a recurrence. Is that what you're saying?
That's exactly what the value of the test
Okay.
is. If you know that you have really aggressive biology,
Mm.
even though it's a small tumor, I think that would be very appropriately treated with a total thyroidectomy.
This is incredible because this gives the patient so much more understanding of what they're dealing with, because there is a little bit of anxiety I've seen in our community from the patients who are seeking RFA for thyroid cancer. When the doctor says it's an appropriate treatment, there's always that little anxiety that they have in the back of their mind. Am I making a mistake and should I have surgery even though I don't want it? What this is doing is it's providing data to help them actually make an informed decision about what is inside of this tumor and is it going to come back. So
Yeah,
this
that's a
is
good way to
amazing.
look at it. It is data. I mean, it's not meant to be a fortune telling
Sure.
uh,
Yeah.
cookie or anything like that, but
Yeah.
it definitely gives you the level of risk and an
Right.
understanding of that, right? If I was the patient and I knew that it was less than a 4% risk, I would be very comfortable to either watch it or do something more conservative.
Qualissure's website says that your testing, quote, measurably improves patient care for thyroid cancer. Can you tell us how so? And what is your perspective on the reduction of aggressive surgery, use of active surveillance, and thermal ablation or non surgical treatment options for papillary thyroid cancer?
With these early tumors, only 19% of them are those type 3 cancers. Right now, a lot more patients are getting total thyroidectomies for those types of tumors than 19%. And so if
Yeah.
you followed the algorithm based on just the molecular features, then I think that it would reduce the number of total thyroidectomies. What it also does is it reduces the incidence of completion thyroidectomy. So, I
Right.
mentioned that situation where somebody gets a lobectomy, then they find some features that are high risk on the final pathology, and then they have to undergo a second surgery.
Mm-hmm.
So that reduces the likelihood of that, because if you trust the molecular test, then you'll stick with the lobectomy. Not only is that better for patients' quality of life, but it also represents cost savings for the healthcare system.
Definitely, definitely. And in one of my previous, just recently recorded episodes, I had an endocrinologist tell me there's a huge difference between having a total thyroidectomy and having a hemithyroidectomy in regards to the patient's thyroid hormone management after surgery, and that their quality of life is completely different. So every time we can reduce the surgery from a total to a hemi, it's always going to help the patient in the long term with their hormone management.
Yeah, I totally agree. I think a lot of people trivialize what's involved with thyroid hormone replacement. They say, oh, it's just a pill. You can take it. It's pretty easy. But, there are adjustments that are required. If it's a little too low, patients gain weight and there's a level of depression.
Definitely.
And if it goes too high, then there's other problems related to that, including anxiety. So, there's definitely an impact on quality of life with imbalances in thyroid hormones. So if you can avoid that, obviously that would have a really positive benefit.
Oh, yes. I even know people who they're hypothyroid and they take medication and they still are constantly having to adjust their hormones and it has an impact on their life. So obviously removing part of the gland or all of the gland is going to have a significant impact on their hormone production and quality of life. So your website says Thyroid Guide PX is a solution to an unmet clinical need.
Thyroid surgeons and endocrinologists have been looking for a molecular test to help to guide their treatment, something that is better than the current clinical risk stratification system, which is the ATA system. Thyroid Guide PX really fits the bill that way. It performs much, much better than clinical risk stratification. Very assuredly gives you information on that subgroup of patients that have a very, very low risk of recurrence. And it's all available preoperatively. So, it's an unmet clinical need. I'm not aware of any other test that does that.
So let's go through the typical testing process for a patient and a physician. First of all, can any doctor order this test, or do they need to be a certain type of doctor? And is it available anywhere?
It is available anywhere, but our testing lab is in Orlando, Florida. So we're really focused on introducing this to the US. Typically, the doctor that would order this would be the person that's doing the fine needle aspirate, the fine needle biopsy.
Mm-hmm.
So that could be a surgeon or an endocrinologist or an interventional radiologist, typically, although any doctor could prescribe it if they wanted to. So it's readily available anywhere, and it's quite different from other molecular tests in that it is specifically built for papillary thyroid cancer, whereas tests like ThyroSeq and Afirma and ThyroPrint and so on, Thyromere, those are all tests that are really developed for the purpose of determining whether a nodule is likely to be cancer or benign.
Okay.
And so they're very helpful for that. This is quite different in that it's specifically for papillary thyroid cancer.
So if I were to go to my doctor and say, I really want this test, all my doctor would have to do is just order it.
Yep, absolutely.
Wow.
So we have those test requisitions online. Of course, as you know, we have a sales representative as well. Let me just walk you through what would typically happen. Say you had a nodule in your thyroid gland. What would typically happen is you get an ultrasound, then the endocrinologist or thyroid surgeon or whoever's doing the biopsy is going to make a decision on whether it requires a biopsy. Once they do that biopsy, they put a little needle in there. Then the cells that are taken out with that needle are evaluated by the pathologist. If the pathologist thinks that this is completely benign, then nothing further is required. If it's kind of in the middle, where they're not sure whether it's benign or malignant, we call that a Bethesda 3 or 4. That is a perfect situation for those other molecular tests that I've described. And then if it's a Bethesda 5 or 6, where you really think this is a cancer and you're going to start treating it as a cancer, that's the time to order Thyroid Guide PX.
Okay. Patient would have this biopsy done, and the same collected cells from the biopsy would be analyzed in this test?
Currently, what we do is we ask the person doing the biopsy to take an extra pass with the needle to put it into our particular medium. Just like with the Afirma test and the ThyroSeq and so on, they all have their own special medium. Once you know that this is likely to be a thyroid cancer, that's the time to utilize that.
Okay. So the patient's already had the biopsy and it comes back that they have papillary thyroid cancer. Maybe they would need to go back and have a second biopsy to get this test if they didn't already have that special pass that you were just referring to?
Yeah,
Okay.
that's true. I mean, our goal really is to try to avoid that.
Right.
So what we're trying to do is encourage people who are doing the biopsy to take an extra pass and just put it in at that same setting so that we
Okay.
can avoid that inconvenience and so on to the patient.
Sure. And that would probably save some cost as well. So, and then how long does it take to get the results after the test is sent to the lab?
Our goal is to get this out within 3 weeks. I think once we get to higher volumes, then we'll be able to get it out much quicker.
Mhm.
Right now, it's about 3 weeks.
And when the patient gets their results, do they get a full report explaining the different subtypes that you're describing?
It does describe the outcomes that we expect with the other subtypes.
Mhm.
So you kind of have an idea of what the outcome is in comparison to the other situations. But then it really focuses on a description of the subtype that that patient has so that they have a better understanding of that.
Okay.
And it's quite informative, of course, to the endocrinologist and the thyroid surgeon.
Because they're going to be needing to make these decisions together. So that's really good. What about the cost? That's the question that all patients are going to want to know is what's the cost for the patient? And is there any kind of insurance coverage for that?
We are actively working on getting insurance coverage. As you know, we're a new test, so it will take some time to get coverage. In the meanwhile, though, what we have is a very aggressive rebate program. And our goal is really to ensure that this test is available to anyone. We have a graded system in terms of the size of the rebate. So people who are financially challenged will, of course, have a larger rebate, and sometimes the testing will be free. Patients who don't have those challenges then will pay a little bit more. For somebody who is non-insured, doing well financially, will pay a maximum of $1,260 at this time.
Okay. And how does the patient find that? It's called the reimbursement navigator. How does a patient find that information?
We have a reimbursement navigator who will contact the patient and explore some of those reimbursement approaches, including payment plans and sizing up the rebate and so on. So we really want to make it easy for patients, and then they can make the final decision at that point whether to proceed with the test. So the goal is to get the test ordered. Our reimbursement navigator contacts the patient and then helps them to decide on whether they want to undergo the testing.
I'm thinking in terms of if this were my situation and I was facing, okay, do I need to just have this test or do I need to go and just have the surgery? I don't think there would be any question in my mind about having this test because I think the information that it's going to provide is going to be so valuable to me as I make the decision about what I'm going to do once I find out the results. So obviously I know there are people who $1,000 is a significant amount of money to, and I mean, it's a significant amount of money to me. But when we talk about the costs of treatment in our community, particularly for thermal ablation, we always try to help patients to think long term and not just what is this going to cost me today? Because you're not just thinking about your financial costs, you're thinking about the costs with your quality of life. And so I think that's so helpful that you've put that together. Now, what about the ultimate cost savings compared to the standard of care with surgery?
There are some significant cost savings when you look at groups of patients. You can't really tell what's going to happen to an individual. If you get information that stipulates that you require a total thyroidectomy, then that hasn't really changed very much in terms of saving money. Mm-hmm. But if you choose because of the information to do active surveillance, then you've avoided the cost of surgery, the treatments of any results of the surgery. And similarly, if your decision is to do something more conservative, then you've saved money because of a less extensive surgery. Now, I just want to say that $1,260 is the maximum that we expect patients to pay, but that doesn't, there are patients who will pay less, of course.
Definitely. You mentioned the patients who do end up having a total thyroidectomy, they've not really saved any expense, but we do have patients who come to our community to see if there's an alternative available to them as far as avoiding surgery. Some of the time we will have patients who decide to undergo surgery and they will say, but I'm glad that I at least looked into this. I got multiple opinions. I'm not a candidate, but at least I did my homework and I know now that I'm making the right decision for me. And so even for those patients who do have this test and then they still undergo a total thyroidectomy, they know when they put their head on the pillow at night, they've made an informed decision and they can sleep well at night having made that decision.
Yeah, I agree. Across cancer types, we know that People who do their own research and are involved with the decision making do better.
Yeah.
And thyroid cancer is not an exception there. We're always continuing to develop potential tools that would be beneficial using the same approach that we use for thyroid cancer. We're now developing tests for lung cancer, colorectal cancer, and head and neck cancer. Those are the next ones on the priority list. They're not readily available. I think we have to do a lot more research before we introduce those to the clinic, but we're always looking for new ways to refine treatment decisions in cancer patients. I think importantly, what we want to do is provide a good service to patients and to doctors, ensure that this test is available broadly. We are very interested in impacting on the way patients are being treated with thyroid cancer, and we want to have a positive influence on that. Very happy to work with patients and with doctors to achieve that goal.
Anyone watching this who is a member of the Thyroid Cancer Survivors Association, THICA, this is a test that I really want to educate that community about as well, because, Save Your Thyroid is predominantly patients with benign thyroid nodules, but the THICA community encompasses all of thyroid cancer. So one thing, where we collaborate a lot is where there's an overlap between our communities. We are starting to see more patients now seeking thermal ablation treatment options for thyroid cancer. Within that overlap, this test just falls right into that population of patients. And so I'm really excited to know about this, and that I learned about it at the ATA meeting this year. That was such a wonderful encounter that we had. So now we're going to move on. We have a few questions from the Save Your Thyroid community. The first question we've already covered a little bit, but I'm just going to go ahead and read it. Are all molecular tests the same? If not, how do I know which test is appropriate for me? Is this test more accurate than other molecular tests?
Yeah, so good question. They're not all the same. The majority of tests that we use for molecular testing for thyroid nodules, the purpose of them is to determine whether a nodule is cancer or not. And examples of that include ThyroSeq, Afirma, Thyromere, Thyroprint. So those are all tests that are built for that purpose, and each of them perform excellent. Our test is very different in that it is specifically meant to help make decisions on patients who have papillary thyroid cancer. It's a very specific test, but it's also built for, high performance because it's been tested on, more than 800 patients now. When do you order this? You order this when you think you have papillary thyroid cancer and you're trying to make a decision. If you have a benign nodule, those other ones would be more appropriate. In order to have this test, does there need to be a diagnosis of papillary thyroid cancer? So you just said when you think you have papillary thyroid cancer. So does it have to be definitively diagnosed as papillary thyroid cancer? No, and that is one of the challenges in the treatment of thyroid cancer as a whole. Most of the time that it's going to be a papillary thyroid cancer because it's the most common type of thyroid cancer, and it has a particular appearance to it under the microscope. But there is a small likelihood that it could be another kind of cancer called a follicular cancer. And in that case, it wouldn't be beneficial, but we've factored that into that possibility. It really is for people who you think have papillary thyroid cancer. The next question is actually about follicular cancer. They're asking, is there or will there be in the future testing like this for follicular thyroid cancer? I'd certainly like there to be. Yeah. I think the reason that we were successful with papillary thyroid cancer is because we had access to large numbers of samples. I think what we need to do is get more data, molecular data on follicular cancers, and then, we could start work on developing a test like that. But that's not something we're going to be able to deliver on in the short term. I really don't know very much about follicular cancer, but my understanding is that papillary and follicular are kind of on the milder end when it comes to severity. And then, of course, anaplastic is the one that's very bad. Can you shed some light on that? So follicular carcinoma and papillary carcinoma are well differentiated thyroid cancers. Anaplastic is a very different beast. It's completely de-differentiated and very aggressive. And then, the treatment approaches are slightly different, follicular versus papillary, mostly because the follicular has a tendency to spread through the blood system as opposed to the lymphatics. Okay.
So with papillary, what we're always talking about is that it tends to only spread to the lymph nodes in the neck and not outside of the neck. Follicular, you're saying, could spread to other organs in the body through the blood. There's a big difference there then about the potential for metastasis. Okay, I thought this was a great question. Should this molecular test be done for thyroid cancer before doing RFA? Is it safe to do RFA on a nodule suspicious for papillary cancer that has never had molecular testing? And this, I'm sure, would just be an opinion-based answer. What do you think, Dr. Bay?
It is an opinion-based answer because, unfortunately, we don't have any long-term data right now for patients with thyroid cancer treated with radiofrequency ablation. But I do know that there are clinicians who are treating thyroid cancer like that, and I think that that's reasonable as long as you're collecting the data and ensuring that the outcomes are similar to surgery. Do I think that this kind of testing is essential for that approach? Yes, I do. I think that it's really important when you're introducing a new technology like radiofrequency ablation that you do everything possible to select the right patients for that kind of treatment. And so if you know that you are dealing with the lowest risk thyroid cancers, which is what Thyroid Guide PX is meant to do, then that's appropriate. My own opinion is if you're going to conduct treatments like this, you should be using molecular testing to enable that selection.
Yeah, and I think back to the scenario that I played out earlier where I was discussing this patient comes in, they have the thyroid nodule that is confirmed papillary thyroid cancer. It's within the right sizes and location boundaries that we've kind of put in place for success with RFA or other thermal ablations. But then they have this test and they find out it's type 3. That completely changes the game for that patient. It helps them know, definitely, this is not the right treatment choice for me. And I think there's so much value there.
I agree. I mean, it would sway my opinion
Definitely.
on what I would want as a patient for sure.
Yeah. Do the Thyroid Guide PX tests require that the FNA be ultrasound guided? Are they willing to receive a stale second batch FNA that has been sitting around for a few weeks while the first batch is being processed?
Optimally, you do want ultrasound guidance because you want to make sure that that needle is going into the tumor and not into the neighboring thyroid gland.
Yes.
So my advice would be to get ultrasound guidance for that. Are we willing to test samples that have been around for a couple weeks until the pathology comes back? And the answer is yes. So, what we really want is for the clinician to take one pass with the needle and possibly two and put it into our media and put it into a refrigerator, not freeze it, but keep it there for up to 10 to 14 days. And then we could perform the testing after that. So the medium is meant to keep the cells in good condition so that we can do our testing properly.
We see so many questions and so many anxieties from patients in our community. And my goal with this podcast is to provide data, resources, expert opinions, and make it accessible to patients. Because, when I was first going down this road, I'm not a thyroid cancer patient, but when I was first looking for thermal ablation treatment, everything that I read was physician-facing material. It was all medical literature, and it was very hard for me to digest and understand what I was reading. So the whole point of this is to just make it so that it is patient-facing and helps patients to understand what's going on in their thyroid gland. Also, sometimes to even help patients understand how important your thyroid gland is. And if you can keep your thyroid intact, that's going to help you live a longer and healthier life, preserve your quality of life.
The patient-facing stuff is super important. When you think about it, efforts like yours really put pressure on the community, the clinician community, to make changes. And it's good. It's not always good, but it's mostly good. We do want appropriate studies on radiofrequency ablation and active surveillance. And I think that those are becoming more accepted. I think probably in the US, active surveillance has not been super popular because it takes a certain type of patient to do that. You need to have low anxiety and confidence in your doctor and capability to come for repeat examinations. So it takes a certain kind of person.
Yeah. And I agree. I think it does put pressure on the physician community as well. we're arming patients with information. When we were in the meeting at ATA where they were training the physicians on thermal ablation techniques, Dr. Tofano made this statement, these patients, when they come to the office after they've been to Save Your Thyroid, they have so many more questions and the appointment takes so much longer. Because they have all these questions, but he wasn't complaining about it. He was saying, you as physicians, you need to be prepared for this because patients want to have answers for these questions. And so I think it's a good kind of pressure. I do have some physicians who subscribe to my channel and to my article platform called Substack. And I hope that will continue and that, that physicians will share this with their colleagues to let them know, hey, you need to know about this. Maybe catch up with what's going on because if you don't, you're going to get left behind. And the patients are demanding it. That's what the doctors are always telling me. This is very patient driven. So that's what we're hoping to do as a community, is to just create some positive change and help patients. So thank you for joining me.
No, it's good what you're doing. It's a tremendous amount of work.
It is.
I can't believe that you've embarked on this journey.
It really is a lot of work. I appreciate you mentioning that and noticing that. It's a full-time plus job, but it's worthwhile.
Awesome.
I can't thank you enough for joining me today. This was tremendously informative, and I think patients are going to find it incredibly helpful.
Yeah, thanks very much for having me. It's been a pleasure.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.